And as far as refractory cases, you mentioned getting GI involved, looking at motility studies. Anything else that we need to be thinking about for patients who we've demonstrated that there definitely is reflux? We've done the pH impedance testing, and then we've tried these medications and things just aren't getting better. What do you do at that point?
Yeah, so then we started having really the conversation about kind of neurosensory reflux, right? With the idea being that you might be having normal amount of reflux that we all have, but the response to it is heightened. And so then we start talking about the use of kind of neuromodulators, such as gabapentin, amitriptyline. Amitriptyline is often used for functional heartburn as well. The idea being that patients are feeling burning, but there's no abnormal amount of acid there. And so we start talking about the use of some of those medications. I've actually started to do a lot of superior laryngeal nerve blocks for irritable larynx syndrome, those type of things. So with the idea being that there, again, is a sensory component to a lot of this, but that, again, that's more of a diagnosis of exclusion, right? So a lot of times patients have to go through a lot of this other testing and empiric trials and all of that. The other thing I will say is if a patient comes to me as a second opinion or third opinion, we still start from the beginning, right? So I still do a good nasal exam, make sure, if I'm concerned about allergies, have we tested for that? Sometimes we need to repeat some of this testing, keep it all kind of within the same time period, because if you had testing 20 years ago, and then you did your PPI trial 3 years ago, is that really where I'm now? So patients, kind of being very upfront about, yeah, I understand you've had this done before, but if we're going to do the second opinion, we got to kind of start fresh here and start checking off boxes. So just kind of expectations for patients, laying them out at the very beginning.